So I term this outcome-guided rehabilitation intervention. Can everybody see this okay? Here? Okay. So again, we want to do an initial baseline assessment of their activities of daily living and various symptoms. To identify the primary rehab barriers. And I don't know how often it is, for example, that even 2 years later, I'm the first one discovering that the person has significant dizziness and recognizing that the individual is saying that it's such a significant rehab barrier that it's preventing them from doing certain home maintenance, for example, or getting involved in certain exercise or certain recreational activities, sports, for example. And I'm the first one at 2 years referring them to an ear, nose, throat specialist to be diagnosed and to a vestibular rehab and balance specialist, when that's crazy because these are some of the most effective treatment tools we have. There's some great physiotherapists doing dizziness and balance-related intervention that in 8 to 10 treatment sessions, not even weeks, treatment sessions in 3 or 4 weeks, can basically resolve these issues to the tune of 90%. But if nobody is casting that wide enough to identify these potential barriers, if you can't identify them, you're not going to then move the person along in terms of dealing with them and treating them. So there needs to be an iterative process of reassessing individuals to then identify, as I mentioned, like the brain injury example, each rehab phase, a different barrier, symptom-related barrier or otherwise, can come to the fore and then kind of be addressed. So basically there are these iterative loops. At some point, the person might need psychological intervention, the first level of it. The second level might be psychological intervention, but now it's more behavioral rather than just in office, learning more coping strategies around pain management, for example, or things like Mick Sullivan's PGAP program, Progressive Goal Attainment Program, which is basically a very structured behavioral program. Despite the fact you have pain, and that's going to be chronic, how do we go about getting you more functional despite the pain? So certainly the psychological community, I think, can be doing a lot more towards moving in the functional realm. Occupational therapists are doing a good job of it, but there's no reason. Mick Sullivan's a psychologist from Miguel, who developed this program, and too few of us are following up on some of these behavioral programs that can take people further. If we're just sitting there in our office, that's great, and we can help people get over things like phobias and post-traumatic stress disorder, panic disorder, depression to a certain degree. But frankly, part of the depression means that my life just isn't the same. I'm not engaged, it's not meaningful. No matter how much psychotherapy you're doing with the person, there's a certain level there that you're really not typically going to be able to overcome until the person's life is engaging, maybe differently, but in a meaningful way enough to sustain them emotionally. And then again here, occupational disability determination and vocational rehabilitation. Occupational disability determination, when we know that plateau is either there or we know that it will occur well short of a person's activity of daily living demands from before, well short of the person's vocational demands before, where that means we need to steer them that direction sooner rather than later. Just some examples of typical vocational rehab, what I'm talking about. So again, modifying the job, accommodating the job.